Good morning, everyone, and welcome. I hope these first few days of fall are bringing you joy as we celebrate the changing color of the leaves and the return of pumpkin spice. My name is Allison Hoons. I'm the knowledge broker and a member of the Arthritis Patient Advisory Board here at Arthritis Research Canada. Before we begin, we would like to respectfully acknowledge that Arthritis Research Canada's headquarters are located on the stolen traditional territories of the Coast Salish peoples, including the Musqueam, the Squamish, and Tsleil-Waututh nations. We express our deep gratitude to the keepers of these lands and waters. I'm thrilled to be your moderator for today's webinar, and I'm excited to learn from our expert, Dr. Derin Karacabeyli. My apologies for the stuttering here on pronouncing your surname, Dr. Derin. Our patient expert for this episode is Eileen Davidson, who's a member of Arthritis Research Canada's Arthritis Patient Advisory Board. If you're joining us for the first time, this webinar is part of Arthritis Research Canada's education series, which was created by the Arthritis Patient Advisory Board in order to share research that's undertaken here at Arthritis Research Canada. Dr. Karacabeyli will give a short presentation and then we'll be joined by Eileen for a Q&A session. Please click on the Q&A icon on the lower right-hand side of your screen to type your questions. We also invite you to stay on at the end of the webinar to watch a 6-minute video prepared for this episode. Now, Dr. Karacabeyli is a rheumatologist who's also a board certified in obesity medicine. He's currently completing his PhD in experimental medicine under the supervision of Dr. Diane Lakai and is studying the effects of treating conditions like obesity and type 2 diabetes on people who live with inflammatory arthritis. His goal is to establish a clinic for patients with obesity and arthritis to help them manage their weight and optimize their overall health. So, welcome, Dr. Karacabeyli.
Thank you, Allison. Okay, perfect. Okay, everybody, thank you for tuning in. And thank you for that introduction, Allison. You did a wonderful job with my last name, which is not the easiest one. So, as Allison mentioned, today we'll be talking about arthritis and weight and the connection between the two of them. Before we start, I too want to acknowledge how grateful I am to live and work on these beautiful lands. These are the unceded traditional territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. I was born here, I grew up here. Such a beautiful place, and I'm, again, really grateful for the keepers of the land. So, the outline for today is as follows. We're going to start by talking a bit about the bidirectional relationship between arthritis and weight. We'll talk about how symptoms of arthritis and medications used to treat arthritis might contribute to weight gain. We'll talk about complications that are associated with obesity, strategies for managing weight when one is living with arthritis, and then we'll summarize some of the latest research on this topic. So, to set the stage, I think it's important to highlight that living with extra body fat is very common. So, in Canada, nearly 1 in 3 Canadian adults has obesity, and worldwide, that number is nearly 1 in 6. And unfortunately, there's still a lot of stigma and bias that exists around obesity and carrying extra body weight. But what's recognized globally now is that obesity is a chronic disease, just like diabetes, just like high blood pressure. And it's a disease that's driven by a complex interplay of genetic factors and environmental factors. It's not a willpower deficiency. It's not a matter of choice. It truly is a reflection of one's biology. Um, and it's also important to highlight that obesity is treatable. And we'll talk about some of the different treatment pillars that we can use to help people manage both body weight and arthritis together. So extra body fat is known to cause inflammation. So the adipose tissue or the fat tissue itself releases inflammatory molecules, which can affect the lives of people with arthritis in a number of ways. First, it can increase the risk of having heart disease or strokes. It can increase the severity or activity of different forms of arthritis, and it can reduce how well certain treatments that are used for inflammatory arthritis, like TNF inhibitors, work. And TNF inhibitors are one of our most commonly used medications in people with rheumatoid arthritis, um, psoriatic arthritis, and axial spondyloarthritis. Obesity also increases the risk of developing many forms of common arthritis, like osteoarthritis, gout, rheumatoid arthritis, psoriatic arthritis, and axial spondyloarthritis. And as I mentioned, arthritis can contribute to weight gain in a number of ways. So, as I'm sure many people who have been diagnosed with arthritis or who are living with arthritis or are tuning into this webinar already know, being diagnosed with arthritis can be life-changing. It can affect how you move through the world. It can affect your energy levels, your mental health. And, with all of these competing demands, it can be really challenging to maintain certain behaviors that you might have been doing before your diagnosis. It can be a lot more challenging to go grocery shopping, to meal prep, to shop for healthy foods, to remain physically active when you're in pain, when you don't have the energy you used to, when your mental health is suffering. Furthermore, dealing with the challenges of having arthritis, sometimes people turn to certain foods for comfort. We call it emotional eating. And oftentimes those comforting foods are sometimes the foods that are a bit higher in calories, and that itself can contribute to weight gain. Further, arthritis can affect sleep quality, and when sleep quality is disturbed, some hormones can be disturbed, and some of those hormones are involved in hunger and appetite. And so when hunger and appetite get affected, that can also lead to different eating patterns, which can contribute to weight gain. Finally, some medications that are used for arthritis flares, particularly inflammatory arthritis flares, one common medication is prednisone. That medication can actually directly cause weight gain. So, in summary, there are a number of ways that arthritis can contribute to weight gain for a person. Obesity is also associated with a number of complications that are relevant for people with arthritis. The first is obstructive sleep apnea, which can affect both sleep quality and quantity and increase fatigue. Obesity is associated with diabetes, high blood sugars, high blood pressure, high cholesterol, and together these are all risk factors for things like heart attacks and strokes. People with obesity are also at increased risk of blood clots, of liver disease, where fat can deposit around the liver and affect its function. And in women, obesity can impair fertility, while in men, it can decrease testosterone levels. Fortunately, obesity is treatable, and there have been major advances in the treatment of obesity in the past several years. This is a slide that I got from a talk that I attended last year by an obesity medicine doctor in the US. And I really like the diagram she created. She created what she called the obesity treatment pyramid. And I like the visual of a pyramid because, you know, with a pyramid, the base of the pyramid forms the foundation upon which the rest of the pyramid is built. And the foundation of the obesity treatment pyramid are behavioral interventions or behavior change interventions. Things like optimizing physical activity, nutrition, sleep, and stress. And then on top of that foundation, medications can be added, or in the appropriate person, surgery can be performed. Now, along the right-hand side of this diagram, we can see expected sustainable weight loss with these different interventions. So typically with lifestyle or behavioral modifications, weight loss on the realm of 2 to 5% long-term is seen, and that can go up to 10% with more, I guess, prescriptive nutrition interventions or diet strategies. When medications are added on top of behavioral changes, weight loss is typically seen from about 5% with some of the older medications up to as high as 20% with some of the newer medications. And currently, there's some medications that are in the experimental phase, not yet available to patients, but we're seeing weight loss as high as 25% with those. With surgical treatments like bariatric surgery, typically weight loss of 20 to 40% can be seen. So, in summary, there are effective treatments for the management of obesity. And when people are able to lose weight through these treatments, outcomes improve for people with arthritis. Studies show that people tend to experience less pain, disease activity improves, the risk of having serious events like heart attacks and strokes goes down, and physical function also tends to improve. So now what I'm going to do is shift a bit and talk a bit about the various pillars that are used in the management of obesity, starting with physical activity. And so physical activity is very, very important for people with arthritis who are living with extra body fat, but it's not so much for the weight loss effects of physical activity or exercise. A lot of studies actually show that exercise is not a particularly effective method for losing weight. It is effective for helping people maintain their weight, but it is very effective for helping with a number of factors for people with arthritis that extend beyond weight loss. So despite not causing a lot of weight loss, physical activity can help a bunch of things like pain, fatigue, physical function, quality of life, and it can decrease the risk of developing serious complications like heart disease and diabetes. Now, I recognize that living with arthritis can be very challenging to start or maintain physical activity due to a number of barriers. And physiotherapists and kinesiologists can be really helpful to work with to overcome some of those arthritis-related barriers. So, in summary, for physical activity, it has a myriad of benefits that extend beyond weight loss. When we're managing obesity, we're not just focused on weight, we're focused on the overall health of the person. Shifting gears to nutrition. So I'm often asked what the best diet is. And typically, what I answer with is I say that the best diet is the healthiest one that a person can realistically stick to for the rest of their lives and still be happy. So the components here that I like to stress are healthy, realistic, sustainable, and enjoyable. And when I say healthy, I like to provide general big picture guidelines as opposed to specific recommendations about what foods to eat and avoid. So what I say is generally speaking, I suggest prioritizing whole foods or unprocessed or minimally processed foods. For example, fresh foods at the grocery store, or if shopping in aisles, ideally looking for foods with five or fewer ingredients. I suggest prioritizing plant-based food sources, things like vegetables, legumes like beans, lentils, chickpeas, things of that nature. And I suggest these because they're often high in fiber, which keeps you full, help with cholesterol levels, reduce the risk of things like colon cancer, high in vitamins and minerals to keep people healthy. And then finally, I suggest ensuring adequate lean protein intake. And there's a number of sources of lean proteins. Those can include plant-based sources like tofu or legumes, can also include things like fish, poultry, dairy, and some other meats. The benefits of protein are there are a number of benefits of protein. One is protein often keeps people full for longer. And two, for people with arthritis, there's a complication called sarcopenia, which is where people lose muscle mass after the diagnosis of arthritis. And there are a number of reasons for this. One is chronic inflammation, another is difficulty maintaining physical activity, but protein helps maintain muscle mass. And so it's another reason why I suggest prioritizing protein. The Canada Food Guide has some excellent resources. And I really like the visual that they've come up with how you fill your plate. And so what they recommend is for half your plate to be filled with vegetables and fruits, about a quarter of your plate be filled with protein sources, and the final quarter with whole grain foods. And I really like this. But what I specifically like about the Canada Food Guide recommendations is they not only provide guidance on what to eat, but also recommendations around how to eat. So they suggest slowing down, eliminating distraction like TV, phone, things of that nature, and eating mindfully, enjoying each bite, savoring each bite, being involved in the cooking process, and if possible, eating that meal in the company of others. And so I think oftentimes what we see is when people are able to slow down and consume their food mindfully, they not only enjoy their food more, often it results in the consumption of healthier foods and fewer calories overall. So shifting gears to talk a bit about medications. So medications are intended to be used as an adjunct or an add-on to the foundation of behavioral modification that we talked about, nutrition, physical activity. So the medications that you've probably already heard about is the class of the GLP-1 receptor agonists, or I'll just call them the GLP-1 medicines from now on for simplicity. The most common one right now is semaglutide. You might have heard of the brand names like Ozempic, Wegovy, or Rybelsus. Those are all different forms of semaglutide. It's the same medication. A newer one that's gaining popularity is tirzepatide, which is branded right now as Mounjaro or Zepbound. And with GLP-1 medicines, typically the weight loss seen is anywhere from 5% as high as 20% with the ones that are currently approved in Canada. And GLP-1 medicines have benefits that extend beyond weight loss as well. They're used to treat diabetes, and they've been shown to decrease the risk of serious events like heart attacks and strokes, as well as kidney failure and death from any cause. Another medication which is used in weight management is a combination of two drugs. It's called naltrexone bupropion, and its brand name is Contrave. Typical weight loss with this is around 5%. And again, similar to GLP-1 medicines, this combo drug also has benefits that extend beyond weight loss. Naltrexone itself can be used for alcohol use disorder, and bupropion itself is used for the management of depression and smoking cessation. So for people who want to cut back on smoking or quit smoking, this can be an effective choice. But once again, the reason why I bring these up is because the decision to start a medication or the decision to explore these options should be made with a healthcare provider who's aware of the risks and benefits of these medicines. It should be an individual tailored choice. And I've only highlighted two types of medicines here. This is not an exhaustive list. There are others. Finally, the third kind of large treatment pillar in the management of obesity is bariatric surgery. And there are a number of different types. Expected weight loss, typically anywhere from, as I mentioned earlier, 20 to 40%. With some of the more we call malabsorptive procedures, it can go above 40%. The two most common procedures that are used in British Columbia are the middle two, the Roux-en-Y gastric bypass, and what abbreviates as the SADS. It's a bit of a mouthful to say the whole thing. But I think, again, I want to just stress that with bariatric surgery, there is significant preparation that has to go in before the surgery is done. And the team very carefully assesses who's a good candidate for bariatric surgery because the procedure is also life-changing. And after the procedure, one has to maintain a number of significant lifestyle changes. So assessing who will be a good candidate, who can benefit from it, and who won't be harmed by potential risks, that's a very carefully made decision. So it's not for everybody, but it is a very effective option. So finally, I'll spend the last 5 or so minutes talking about some of the research that we've been doing here at Arthritis Research Canada, looking at the effects of these GLP-1 medicines in people with inflammatory arthritis. And so our focus, inflammatory arthritis, is on rheumatoid arthritis, psoriatic arthritis, and axial spondyloarthritis. So first, a couple of years ago, we did a review where we looked at all of the studies that had been published on these GLP-1 medicines in people with inflammatory arthritis or psoriasis. And what we found was that while there was some encouraging studies in labs, so for example, in cells or in mice, there was little research in humans. So the lab studies in cells and mice showed that the GLP-1 medicines had anti-inflammatory effects, reducing inflammation, which is a good thing, and cartilage protective effects, so reducing breakdown of cartilage, for example, in the joints of mice. However, it's still not known, or it wasn't known at the time, and a lot of it's still not known, how this translates to humans. So we have set out to try to answer some of these questions. So we conducted a study last year looking at the effect of these GLP-1 medicines on the risk of major heart events in people who had diabetes and immune-mediated inflammatory diseases. So immune-mediated inflammatory diseases, it's an umbrella term that includes the different inflammatory arthritides that I mentioned. It also includes what we call systemic autoimmune rheumatic diseases. So diseases where the immune system is dysregulated or not working as it's intended to. And as a result, it can lead to problems such as lupus, vasculitis, inflammatory bowel disease, and so on. So it's a big category of diseases. And what we found was that in people who had these immune diseases, those who were taking GLP-1 medicines for diabetes had 52% lower risk of death from any cause and 34% lower risk of serious cardiovascular events, which includes heart attacks and strokes, compared to people with diabetes who were taking other diabetes medicines that are not known to affect your risk of having things like heart attacks or strokes. So we found that there was a protective effect of these medicines on heart health. The next study we did is we looked at whether or not taking these medicines, these GLP-1 medicines, might affect a person's risk of actually developing an autoimmune disease. We thought, if these medicines might have protective effects, could they prevent somebody from developing an autoimmune rheumatic disease like rheumatoid arthritis altogether? We did not find that to be the case. We found that for people with diabetes who took GLP-1 medicines, their risk of developing an autoimmune rheumatic disease was neither increased nor decreased. It kind of remained the same. So what's next? What we're currently doing is we're looking at semaglutide. Again, the brand name is Ozempic. We're looking at whether or not this medicine is safe and effective at improving disease control in people with inflammatory arthritis and diabetes. We're seeing if receiving this medicine decreases a person's chances of having a flare that requires their inflammatory arthritis treatment to be increased. As Allison mentioned at the beginning, another thing that I'm working on is developing a clinic, which will include many health professionals, myself, physiotherapist, dietitian, nurse, social worker. And it'll be a clinic for people with obesity and arthritis to help them with weight management and optimizing their overall health in the context of having arthritis. So that'll look something like this. The patient will be in the middle, the focal point, and around them will be a team of people who are communicating and working together to try and help that patient manage their weight in the context of having arthritis. Finally, I'd like to highlight a few useful resources if you're interested in learning more about the topics of nutrition, obesity, physical activity, or the management of arthritis. So Obesity Canada is a wonderful resource. Their website has lots of patient-centered resources. The Canadian 24-hour movement guidelines has really helpful information on physical activity, as well as other things around sleep and things of that nature. I've mentioned the Canada Food Guide already. Through Vancouver Coastal Health, there's a service called Oasis that some of you might have already heard of, Osteoarthritis Service Integration System. But on the website for Oasis, there are a number of really helpful resources, sessions that are free on things like mindful eating, supplements, physical activity, and many more. They're intended for people with osteoarthritis, but I think that people with other forms of arthritis can also benefit from the general education, so it's something to consider checking out. And finally, if you live in British Columbia, um, you can call 811 between 9 a.m. and 5 p.m. on weekdays, and you can speak with a certified exercise professional or a registered dietitian for free for more information on physical activity or nutrition, if that's something that interests you. So with that, I will end, and I look forward to the discussion that follows. Thank you.
Thank you so much, Dr. Karacabeyli, for that superb presentation. It was a wonderful journey through the research, and it was presented so clearly and with such authenticity. And I learned a tremendous amount, and I feel like the that image of even the food in different parts on the plate, that there's all these different components to the management of our arthritis and, exercise and arthritis and obesity, including the exercises and these medications and everything. And I almost see the plate analogy in the same way for all these different things. So thank you so much for a superb presentation. We're now going to start the Q&A session, but before we begin, I would like to formally introduce our patient partner, our patient expert, Eileen Davidson. Eileen is a person living with rheumatoid arthritis and a member of the Arthritis Research Canada's Arthritis Patient Advisory Board, as well as being an arthritis blogger and a patient advocate. And we're going to be showing you later the video that was made as Eileen shared her journey with this. She's been involved as a patient partner in countless Arthritis Research Canada research projects, and she'll be bringing the patient perspective to the Q&A session. So I'd now like to invite you to share your questions. If you migrate your cursor down to the bottom of the screen, you will see that there's a Q&A box and you can type your questions in there. And if you really like the question that somebody has posed already, you can upvote that by clicking on the thumb so that I know that there's several people that are interested in that question. I'll do my best to navigate through the questions. There might be some that I might miss, and I ask for your indulgence in understanding that if I miss it, it wasn't done with intent. So I'd like to begin. One of the first questions well, first of all, people are asking, will you receive a copy of the PowerPoint and a recording? Yes, you're going to receive an email with a link to, and on our website, there will also be a link to the recording as well as the list of resources that Dr. Karacabeyli has kindly shared with us. So that question I can answer. But the first question that was asked, and I think is appropriate for you, Dr. Karacabeyli, is, are there some people who just cannot take some of these newer medications, such as people living with reduced kidney function?
That's a great question. And the answer is yes. The medications are not for everybody. For example, if you have very low kidney function, that is a reason to potentially not take these medicines. Another one is some of these medications have what we call contraindications, where there are reasons to absolutely not take them, and a doctor should be aware of these things. But for the GLP-1 medicines, there's a rare thyroid condition. It's called medullary thyroid carcinoma. It's a type of cancer in the thyroid. If you have that, if you have a history of that, or if a family member has that, that's a reason to absolutely not take the medicine. So yes, they're not for everybody, and the safety is being explored more as we move with time. But thank you for that question.
Hey, Eileen, I see a couple questions here that I think might be really helpful to have your perspective on. First of all, someone has shared that since they were diagnosed with rheumatoid arthritis, they've had a change in cravings for, in their case, sugar. But what's your experience has been, what has your experience been in regards to cravings, for example?
Well, it's up and down. Also, there's a number of factors that can go into that. So depending, like in the beginning of my diagnosis, my depression and anxiety was quite a bit higher. So that probably led to binge eating for dopamine response, or certain medications that were on. I've also noticed really impacted how hungry I was all the time, particularly prednisone was very easy to gain weight because I had a lot of cravings on it. But I even also experienced that on Rinvoq. So it's sometimes it's not just prednisone that causes it. And then there's also our other medications like mental health medications. Some might cause an increase in appetite. And so I guess it really did affect it because of a number of different factors from depression and medications, and then also just kind of, I think, being bored when I stopped working full time. Um, you filled that time with eating. So yeah, I think that is true. Maybe Derin can talk about it on a scientific level, though.
Thank you, Eileen. Darren?
No, that's fair. I think, Eileen, you captured it really well. I'm not aware of any studies specifically looking at increases in like sugar cravings, for example, but as Eileen said, when people are under significant stress, whether that be physical, psychological, social, um, emotional eating is a common coping strategy. And as I said earlier, I think often people find comfort in foods that are higher in sugar. And so that can be common as well.
Thank you. There's another question just generally, and I know that many people on the call may not have inflammatory arthritis. So is there any anticipation or anything in the literature that you're aware of, Darren, in regards to the potential benefits of this GLP-1 medications for non-inflammatory conditions?
Yes, actually, the strongest evidence right now for these medicines is actually in osteoarthritis. So currently, the evidence for these medicines in inflammatory arthritis in humans is rather limited. Whereas in osteoarthritis, in October of last year, there was a big study published in one of the most prestigious medical journals in the world that showed that with obesity who had osteoarthritis who received semaglutide, those people had reductions in pain and improvements in physical function that were significant. They were not only significant on a statistical sense, a scientific sense, but they were practically significant. For example, people who had, a pain score that started off at a 7 out of 10, if you get a placebo medicine that drops sometimes to about a 4 out of 10, with these medicines that drop to about a 3 out of 10. So it was a big difference, and that generated a lot of excitement. There's also been some observational studies that study was actually an experiment. It was a randomized control trial, so it was a very well done study. Um, there's also been some observational studies that show that people who get GLP-1 medicines have a lower risk of progressing to need a knee replacement, for example, if they have knee osteoarthritis. But those studies are observational, so we need a bit more data to confirm those findings. All that said, right now, I would say the evidence is actually strongest to support GLP-1 medicines in people with osteoarthritis and either obesity or diabetes, as opposed to inflammatory arthritis.
Thank you. I see a number of questions that have come in have asked about your clinic. Any ETA on when that might be happening?
Well, that's very encouraging. Thank you. Currently, no ETA. We're in the process of moving it through the appropriate channels through the Mary Pack Arthritis Center. That's the goal, is to hopefully host the clinic there. I had a meeting with them in May and then in August, and so we're just moving through it. But unfortunately, no date yet. Um, Hopefully, in the next couple years.
Thank you. There are some questions in here specifically about exercise. And so I'm going to start with Eileen. I mean, you live with, as you were explaining, so many things that can affect your energy and ability to exercise. What are your If you were chatting with somebody who's just starting on this journey and saw in that slide the importance of the foundation being physical activity, what would be your tips or tricks or guidance for them in how to start with that, and importantly, how to maintain that if possible?
Well, first thing first is start small and slow. Don't try and dive into a long exercise routine that your body isn't going to be able to handle right away. Because when I find I start exercising, especially for the first 2 weeks, I end up with higher fatigue, not necessarily higher pain. It actually helps reduce my pain quite a bit, but it really does spark fatigue at the beginning once I start being more active. But that does eventually kind of reduce, and exercise actually starts helping me sleep better at night. It actually helps me control my cravings. Helps my mood. There's so many reasons why I love exercise. However, it is very difficult with rheumatoid arthritis, with pain can be a huge reason why I can't do certain exercises. So, particularly, I really like the elliptical because it's a full body exercise and it's low impact on my feet and my knees. And then I also like strength training with either like resistance bands or like weights under 10 pounds. They're still going to do something. And just having the guidance of like a physiotherapist or your kinesiologist. I learned through Arthritis Research Canada, the iStart program, as well as I went to the Mary Pack Arthritis program too. They helped me, really helped me learn to exercise with um, rheumatoid arthritis. I also have osteoarthritis and fibromyalgia. So I'm coming at this from a couple forms of arthritis, you could say. And yeah, so I say start small, and also one thing that really helped me was exercising in the morning. So before I maybe have hurt my joints over the day by cleaning the house, or before I'm too tired. And it actually, I find, yes, I need the first a few naps at first, but over time I'll have more energy during the day, and then I don't make excuses much to not exercise. Um, and then yeah, so I think exercising in the morning, while I call those my good hours. And then, of course, if you want to keep this up, you have to do the exercises that you enjoy and the ones that you actually, feel comfortable doing. Over time, you can add in more, try out different things, but do the ones that you enjoy. Um, and yeah, start small. Did I
Very
answer the
sage
full question?
advice. Thank you, Eileen.
Mhm.
Darren, there's several questions about what happens. Do you have to be on these medications for life? And what happens when you stop? Do you want to address that concept?
hmm Before I do, I just want to highlight that was such a wonderful answer from Eileen for the previous question. I think it's so helpful having your perspective. That was really enlightening. So thank you. Um, yeah, so yeah, in terms of do I have to be on these medications for life? Very common question. It's a very good question. What we know right now, again, based on large studies that are experiments or randomized control trials, is that when people stop these medications, even if they go off these medications without realizing they go off these medications. So in these experiments, sometimes at a certain point in time, they will say to people, okay, randomly, half of you are going to get put on a placebo medication. So it's no longer going to be effective, and half of you will continue, but you don't know if you're continuing or not. So continue all your behaviors the exact same way. Continue your physical activity the same way, your nutrition the same way, change nothing. You might get switched off the medication, you might not. In those studies, what they find is that people who get switched off of these medicines regain about half to two-thirds of the weight they lost over like the next year or so. So weight regain is common. People don't regain all the weight back, it seems, but they regain a lot of the weight back. And that's even despite not really changing much else. The challenge right now, practically, is that these medications are expensive for people without diabetes. They're not covered for people without diabetes. So for people who are taking these for obesity, making the decision of do I have to stay on this for the rest of my life, paying as of right now, somewhere between $3,000 and $5,000 a year, that's tough. And so right now we're kind of in the infancy stage or the early stages of research looking at what strategies can we employ to help people either reduce the use of these medications over time, or taper off of these and use other strategies to try and maintain the weight that's been lost. In summary, we know that a lot of weight will be regained when these are stopped. And so right now it's encouraged to stay on these in some form long term. But practically, some solutions that are being explored are tapering the dose. So, for example, going to the lowest dose possible, so it's a little bit more economical, or using, if it's a weekly injection, going to every 10 days or every 2 weeks. That's something that's being explored. Or even switching to some of the older generation medications that help with weight loss that are a lot less expensive. So an example that's not really thought of much as a weight loss medication, it's not approved for weight loss or obesity, but metformin, another diabetes medication, has been shown to help people lose about 3% body weight, up to 5 maybe. So people are looking at strategies to reduce or get people off GLP-1s and onto either something else or increase other behaviors that might help keep the weight off. The other one I'll mention is exercise. So one study found that I believe it was one study found that a supervised exercise program helped people keep off more weight as they were tapering down. So unfortunately, as of right now, it looks like you do have to stay, or it's encouraged to stay on these long term, but we're exploring strategies to try and get off of them.
Thank you. I think, that honesty is so important, to know at the beginning before you start something what you can expect. And, is it something that you have to be on long term and what are the repercussions for it? But it's also encouraging to know that not all of the weight is gained back if you need to stop for any particular reason.
Can I mention one more thing about that, Allison,
Please
before you go on?
do.
So one other thing that I thought was helpful is people have said, or a lot of experts in the obesity community have said that, we should start thinking about obesity like diabetes or high blood pressure. So if you're on, for example, a high blood pressure medication and you go off of it, your blood pressure typically goes back up. If you're on a diabetes medication, you go off of it, your blood sugars go back up. And so the thought is similarly, if you're on an anti-obesity medication, you go off of it, often your weight comes back up to some degree, if that's a helpful analogy for people.
Thank you. Yeah, very helpful. Eileen, there's some questions from people, and I apologize to people. I'm not reading out your exact questions because I'm looking for common threads, common concepts that are in the questions, rather than specifically reading out your individual questions, and also acknowledging that there's some really good questions and important questions that people have asked, but they're about their specific situation, that they're on a particular drug and have tried doing this, etc. For specific questions, generally those are best addressed by your healthcare provider in a one-on-one conversation. It's not always advisable to have someone that's not familiar with your full history answering those questions. So I'm just asking that, or just acknowledging that I cannot ask all the questions that are in the Q&A, but that doesn't devalue how important each of the questions are. And Derin, thank you for also referring to the expense, because there were quite a few questions regarding to the expense. So you segued nicely into that part. Hey, Eileen, there's some questions that people are asking about length of time, what experiences and length of time to lose weight. Did you want to address that? How long it takes when you've noticed weight gain and then you undertake some strategies to deal with it? Do you want to speak to your experience about that?
Well, I guess it depends on time of year, how active I am. Obviously, weight gain tends to happen more easily in the winter. And then less in the summer because I'm a little bit more active. And also, I'm a gardener, so I grow a lot more fruits and vegetables then. Um, so to get it off, though, everybody's different. And it could be a number of contributing factors. When I was in my early 30s, it was a lot easier to get off. Now I'm 39 and it's harder to get off. So age is definitely one thing that's kind of slowing it down for me. But I would say like when I do exercise, and I will say I like the elliptical and then I like the sauna after. That's like my happy place. Um, I do feel lighter after. My clothes fit better, and I could feel a difference, maybe not noticeably, like physically, you can't see it, but I do feel a difference in my body the first time I exercise. Maybe it's a placebo effect, maybe it's not, but I think it does actually take about 4 weeks before you can start seeing a difference if you're, eating healthy with a limited amount of calories, and then also regularly exercising 3 to 4 times a week. And then also maintaining, like, I like to do 3 to 4 times a week with strength training, and then I walk or do elliptical every day. Obviously not strenuous ones. So that's important to keep in mind as well. If you are following a consistent plan, you will see more results faster. Did I answer that all?
Absolutely. Thank you. Yes, there's a question in there that I might be able to address. And it's how can I find a physiotherapist in Vancouver that specializes in arthritis? Well, not only do I live with arthritis, but I am a physiotherapist. And you can just Google find a physio. Which is the BC Physiotherapy Association, a listing of physiotherapists. And when you go in, there's a drop-down menu that you can choose areas of specialty. So you can choose arthritis and find a physio who specializes in arthritis. But Eileen, do you want to talk about, share a little bit about Mary Pack Arthritis Program and other places that you've gone for help?
Yeah, so I definitely find that there is a difference in physiotherapists who have advanced training in arthritis compared to others, although I think that's because they took an extra interest in it. But the Mary Pack Arthritis Program has physiotherapists that have taken advanced training and have actually developed a course of advanced training for arthritis. So I have gone there. Now, because they do that training, there are advanced physiotherapists throughout, I think, BC, maybe even within Canada. There might be other programs, but if you ask your rheumatologist if they know a physiotherapist that has advanced training, they might be able to refer you to somebody that they would recommend. And then you might be able to also ask them for a referral to the Mary Pack Arthritis Program if you're in, I believe they have one up north in Kelowna or Vernon. Somebody correct me there, or Vancouver or Victoria.
Thank you. Yes, and on their website, all of those locations are there. But yes, a referral is needed from your physician. You're quite right. Um, Derin, couple more questions. Um, One individual says that she's heard from her rheumatologist that there's a biologic medication that's either in trials or testing right now that might be including a GLP-1. Are you familiar with this? And if so, any thoughts?
Yes. So right now, they're testing, it's for psoriatic arthritis, but right now they're testing a combination of an IL-17 inhibitor. I believe it's ixekizumab that they're testing, but they're testing that alongside a GLP-1. I think it's with tirzepatide that they're testing it, but that combination is being used to see if it helps people with psoriatic arthritis who also have extra body fat or obesity. That's in the works. There's two studies, I think, ongoing, one in psoriatic arthritis, one in psoriasis. Hopefully, we'll see results of those in the next, I think, 1 or 2 years, I believe. There's also, this is not specifically for people with arthritis, but in people in general, there's also, they're testing this new biologic molecule. It's called bimagrumab, but it's a molecule that's intended to help people increase or maintain their muscle mass. And so while still losing weight. So they're testing that biologic combined with a GLP-1 as well. And some of the preliminary results look promising, but again, that's in people with diabetes or obesity. It's not specifically in people with arthritis, but that's another combination with GLP-1 that's somewhat exciting.
Thank you. Another question for Eileen. How do I do upper body exercises when my hands can't hold weights, tubes, or bands? Do you have any experience in that and some ideas for people?
Um, you can, if you can hold something like a can, soup can, that can even be a weight, or there are plenty of body weight, just your own body weight exercises. That would be also something that I think that if you can get access to a physiotherapist, to definitely get some guidance for that.
Right, and there's actually something that you can order quite easily called weightlifting straps or weightlifting wristbands, and that's what I use in the gym. So it's a band that you strap onto your wrists and around whatever it is that you're holding, so that your hands aren't actually holding it. The band on your wrist is holding it, so it relieves the pressure on your fingers. But yeah, if you can get to see a physio or a kinesiologist, that would be great. Um, let's see. There's a few questions regarding the muscle loss component of GLP-1 medications. Derin, would you like to address that?
Sure. So, with any weight loss intervention, whether it be a diet, whether it be surgery, whether it be GLP-1 medicine, there will be some degree of muscle loss with weight loss when someone's in a caloric deficit. The part that can be concerning is the degree of that muscle loss. And so in one of the big GLP-1 studies, the one on semaglutide, what they found was that the amount of lean mass loss, this might get a bit technical, but I'll try and keep it as clear as possible. But what they found was the lean mass loss was 39% of the total weight loss. And typically in like older diet studies and things like that, with diet, a rough rule, and I know it varies, but a rough rule is about 25 to 30%. So this was 39%, and that concerned people. And they said, well, people are losing all this weight with semaglutide, but are they just losing muscle? Are they not losing fat? Now, what where the distinction where it becomes a bit more hazy is the way they assess for muscle loss in these studies is using what's called a DEXA scanner. And so a DEXA scanner doesn't actually measure muscle at the tissue level, it measures kind of fat mass and fat-free mass. And so what they find is that people lost 39% of the fat-free mass. Now, adipose tissue, or like true fat tissue, has about 15% water. So if you lose 6 kilograms of true fat tissue, you are actually losing about 1 kilogram of lean mass or fat-free mass, which is water. And so, after this study came out and there was all this concern around muscle loss, people started to dive into the nuances here and started to discover that right now it looks like the amount of muscle loss with GLP-1s is probably proportional to the amount of weight loss, meaning that you're not losing a disproportionate amount of muscle with the GLP-1, but right now we're still in very early days. So I think the bottom line of this is that with the GLP-1 medicine, it is expected that there will be some element of muscle loss that will be proportional to the total amount of weight loss. And the strategies to offset that muscle loss are ensuring you're getting enough protein. So a rule of thumb, again, this is rough, it'll depend person to person, but somewhere around 20 to 40 grams of protein per meal. Um, and then the other one is trying to get at least 2 days of resistance exercise or physical activity per week to help with the muscle maintenance. So those are the two strategies we recommend. We need more science. But initially, some of those alarm bells might have been a bit overstated based on what the science actually showed.
Okay, so if I got this right, then the take-home message is yes, there will probably be some muscle loss, but that muscle loss is um, a, not a huge concern, and you're best to counter that, assume that that's going to happen, and counter that by prevent as excessive loss of that muscle by maintaining strengthening exercises if you're on a GLP-1 medication.
That's a pretty good summary. I would say the one thing I would say is the muscle loss is still a bit concerning with anything. Like if people go on a big diet or if they get surgery, we are concerned about muscle loss. Same with GLP-1s. But as you said, Allison, we want to follow those strategies with the exercise and the higher protein intake to try and offset that expected muscle loss.
And we're just winding up because we do want to save a little time for the video, but there are a couple more questions that I see that a number of people could benefit again from. And again, I apologize that we're not able to address the questions that are about specific individual situations. Those are best addressed with your healthcare provider. So first of all, how much of weight loss could you proportion, Derin, to watching foods that you eat versus exercise? Is there anything known about proportionally how much each contribute?
Again, this is rough. I'm not even sure if this is based on, this is what I've heard, but I can't actually recall a study that showed this, but what I've heard and been taught is around 80% nutrition, 20% physical activity. It's much more heavily influenced by what one eats as opposed to how much exercise one does.
Okay, thank you. And then what are there any pain medications that are safe to take with non-alcoholic liver cirrhosis?
With cirrhosis, it's challenging. I would speak with your family doctor about that one, or if you have a liver specialist, I would speak with them about that one.
Okay. Thank you. I think we'll stop there on the questions. We will always we address any remaining questions on the webpage. We do our best to address your questions that weren't able to be answered in the webinar. I really thank you all. It's the participants who attend not only in real time, but those that watch the recordings later. This is why we do it. We do these sessions for you. And so your participation and your questions are really valuable, because when you ask a question, I bet you that there's other people who are thinking of a very similar question. So thank you all for sharing your questions. We also want to thank the Arthritis Research Education Series sponsors for their support. So those include AbbVie, AstraZeneca, Biocon Biologics, Celltron, Organon, Pfizer Canada, Sandoz, and UCB Canada. We want to especially thank our presenter today, Dr. Karacabeyli, and to Eileen Davidson, who shared her personal story in the video that you're about to see. And for those of you who haven't had the opportunity to visit our website and check out the Arthritis Research Education Series, I strongly encourage you to do so, because there have been some amazing sessions. So you can look at arthritisresearch.ca/learn. We've got lots of episodes on a variety of arthritis topics that are related to the research that's undertaken here at Arthritis Research Canada. We've also got a pile of resources that have been vetted for their credibility, and sections on frequently asked questions. We'll also, after the video, we will be sending you a quick survey, and we hope that you'll find a few minutes to complete it. Your feedback on these sessions is really important in planning for subsequent episodes. And everyone who completes our survey by October 8th will be entered into a draw for a $25 Amazon gift card. So we hope that you will find a few minutes to do that for us. We're now going to play the video for you. It's approximately 6 minutes long, and thank you all.
Arthritis is so much more than just joint pain, and obviously joint pain is going to get in the way when you want to be physically active. But there's fatigue, down to your bones, fatigue where your body's heavy, you can barely move some days. Seeing how people are different to you when you have a disability, especially when your disability causes weight gain. So there's a lot of negative emotions that come with living with arthritis and having excessive weight. I was diagnosed with rheumatoid arthritis at 29. I found that I started to really blame myself for the pain that I was experiencing, because I did try to exercise, I did try to eat healthy, but it wasn't working for me because I had many barriers that I didn't know I had. I've had to learn how to be physically active again while living with rheumatoid arthritis.
A diagnosis of arthritis can be life-changing. It can affect a person's energy levels, their mood, and how they move. And when you're diagnosed, that can really affect your ability to maintain certain habits. Once you're diagnosed with arthritis, because it can be so hard to maintain these things, weight gain can be common. In addition to that, some of the medications that we use to treat inflammation in the acute phase, medications like prednisone, that can promote weight gain. On top of that, arthritis itself can be associated with stress, and it can affect your sleep. And we know that both stress and sleep can affect hormones that regulate appetite. So when we put all these factors together, it makes a lot of sense why it can be really challenging to maintain your weight after a diagnosis of arthritis.
Like most women, I gained weight after my pregnancy, and I really struggled to lose the weight at first, especially while I was going through undiagnosed rheumatoid arthritis and while trying to find a medication that worked for me. I did find that certain things did help me exercise more, like low impact exercises, the elliptical, swimming, going to the sauna after to relax my muscles and joints. Medications have been a big part of my weight management journey. When I had a biologic that was working to treat my rheumatoid arthritis, exercise was a lot easier for me. I didn't have to deal with as much foot pain or knee pain. So I was able to lose 60 pounds with the elliptical and swimming, going for walks.
So one class of medications that's become increasingly popular in the past several years is the class known as the glucagon-like peptide-1 receptor agonists, or GLP-1 receptor agonists. Within this class, the most well-recognized medication is semaglutide currently, which is branded as Ozempic for diabetes. Recognizing that obesity is a state of chronic inflammation, we were interested into looking into whether or not addressing obesity through medications like GLP-1 receptor agonists could reduce the risk of cardiovascular disease in people with inflammatory conditions like arthritis. We found that in people receiving GLP-1 receptor agonists, they actually had, similar to the general population, lower risk of things like heart attacks, strokes, death from cardiovascular causes, and death from any cause during our study period when taking this medication class versus another medication class that has been shown to not affect the risk of cardiovascular disease. So I like to break the management of obesity down into different pillars. So pillar one revolves around health behaviors. So interventions that we can implement to help people adopt healthy behaviors. Things like optimizing sleep, stress, physical activity, and nutrition. And the beauty of this pillar is that this forms the foundation of the rest of our treatment strategy. And there are a lot of benefits to these things that extend beyond weight loss. Pillar two is our pharmacotherapeutic pillar, or our medication pillar. So what can be added on to pillar one, the behavior change pillar, in order to, again, facilitate weight loss and improve overall health. And then finally, pillar three is our interventional or surgical pillar. In the appropriate person, is bariatric surgery indicated to, again, facilitate weight loss and improve overall health?
There's been a number of things that I have to do regularly to manage my weight. Exercising regularly, managing sleep, making sure that I get a good 7 to 8 hours of sleep at night, and making sure that I'm eating a nutritious food map. I will chop my vegetables and keep them in containers ready to grab so I can either make stir fries or salads with them. I even meal plan smoothie bags so that when I'm tired in the morning, I can have a nutritious smoothie and just grab it out of the freezer and have it ready. I keep a meal plan up on my fridge, and I actually really enjoy developing healthy recipes myself. Participating in research has opened the doors for me to connect with researchers who really understand exercise with arthritis, particularly kinesiologists or physiotherapists who have been developing interventions to help people like me. There's lots to learn when it comes to navigating this disease and how to self-manage it. But a lot of the things that we can do to self-manage our condition will actually end up helping us reduce the excess of weight and get healthier.